is going to pick up with where we are. Perfect. So let's rewind. Give me the 5 antihypertensives, except you got 2 A's, so technically 6. Start with your A's. So ACEs, ARBs, betas, calcium channel blockers, D, diuretics, and E, ED. So that's your vasos. All right. So ACEs and ARBs work where? On RAS. You're going to figure out that by the exam, just so you know a little bit more about it. Betas. That's on your beta cells, your 1s and 2s. Then you got your calcium channel, muscles, diuretics, kidneys, your sodium channels, EDs, just going to vasodilate, so it's going to relax them. If they had a dry hacking cough, what drug might be the culprit?
ACE.
Or
ACE
Yeah.
for a dry hacking cough. What about if they get put on an antihypertensive medicine and the doc's wanting to enhance their cardiac coverage? What 2 classes of meds may they also get added on? Statins and
Blood thinner.
and some sort of blood thinner, usually aspirin, which is your salicylate. We'll get to those in this class. What about, who would you not want to give a beta blocker to?
Heart patients.
I like heart patients. What kind of heart patients? What problems would they have?
Third degree heart block.
So I like heart blocks would not be good.
Brady.
Heart failure, bradycardia, love all that. And then asthma patients, because it could cause a bronchospasm. Calcium channel blockers have one big side effect that you're worried about. Not one big, there's several, but calcium channel blocker might be what to them. I like that one. That's the big dangerous one. I'm more worried about orthostatic hypotension over the constipation. So what are you going to teach them to do? All that. Give me some antibiotic teaching. Second plan of birth control. I like it. What? Take them all. Take them till they're gone. What else? Probiotics. Sunscreen, sunblock, all good things. I like it. You see, this is pretty easy. I think you're gonna be all right. What about which medicine is gonna cause some hyperkalemia in the antihypertensives? Like spironolactone will cause it, but in the which one? Your ARBs. Your ARBs, bad for hyperkalemia. Let's see. Why don't we like first gen antihistamines? They do. Lots of bad side effects we don't want, so do a second gen, something like that. Analgesics, you got your opioids, easy enough. These come from fancy little plant. Y'all, what flower? Opium flowers. I like that. And then you remember poppies in the Wizard of Oz? Like poppies? Don't remember that? Wizard of Oz?
Yes.
Okay. I was like, that gum, that old, that's not even, can't use Wizard of Oz. But anyway, you're worried about most of these being plant-based, though there are some now that are chemically created. Your first line there, those are just more of your commons, just your good moderate pain reducers. And then you've got your severe pain reducers, the big guns, Dilaudid, fentanyl, and there's a lot more heavy hitters, Demerol, Butrex, lots of ones that way. But morphine and Dilaudid, most of those will be. What do you need to know about those? What do they do to you? That's your big one. And if ID, CNS depression, which causes the respiratory depression. So your opioids cause CNS depression. I'm worried about respiratory. Yep. And so what condition might your patients go in if they have overdose of opioids? Because they're not breathing. They have impaired ventilation.
Yeah.
Respiratory what? What balance though? Respiratory acidosis, because they're not breathing, so you're holding on to CO2. So opioids can cause respiratory acidosis. Then what's your antidote? which is your generic? Naloxone, perfect. We would give that if need be in severe cases. So, what are you gonna do if your patient's hurting and they're complaining of pain 10 out of 10, their blood pressure's like 80/40? What you, huh? Yeah, but what you're not gonna give them? You're not gonna give an opioid, because you might as well just snuff them out. So, you're gonna use, hint, hint, one of these other classes. So if there's a question on the exam, here's your patient, they're complaining of severe pain 10 out of 10, here's all their vital signs and chart to review. Do not pick the morphine if they are knocking on death's door. Pick another option, because you're still addressing the pain, you're still doing something for it. It's not what we would like to do for it, but based on their vital signs, you cannot give them an opioid. Let's talk about this. This is on a different slide. What if your patient is accustomed to taking chronic medications for pain at home? So if you give them just obviously if their doctor orders something less than what they're accustomed to taking to at home, they're in an acute phase, they ain't doing nothing. Just go ahead and pick up the phone. So get them at least at baseline of what they're accustomed to taking at home, and then add a little something in there. So go ahead and continue those chronic pain meds and add a little sprinkling on top to help them, but that's on the next slide. NSAIDs, when that comes to mind, what you worried about? Your big GI bleeds, your big one, and your renal function. So ibuprofen, carbuprofen, naproxen, there's another oxen I can't think of, ketorolac, there's several other lacs, but those are your NSAIDs, so you're worried about GI bleeds and kidneys there, and those are for your mild to moderate pain. And then your salicylate, or acetylsalicylate, aspirin, you may see it shortcutted ASA. Aspirin, in my opinion, does not help a whole lot of pain on its own, but in like goody powders, or which don't take goody powders because that's a big GI bleed, but like the same combination of drugs, so it won't come to my brain at the moment. Excedrin, that has like the caffeine, acetaminophen, and aspirin. It's good in my opinion in a mixer. That's not necessarily a test question, but I just like you to know that aspirin on its own is generally more for what two conditions? We've already addressed one, for bleeding, to help thin out blood for your cardiac patients, and what's else aspirin good for?
Antipyretic.
Who? Yeah, love it. For fevers. Good job, Zach. So antipyretic. Good with those. But for pain purposes, you can just make a little footnote or whatever, just for real world scenarios, mix it with something else. And then your non-saliculates would be your acetaminophen, down there in their own class. So your real worry with acetaminophen is their liver, because we're gonna punch out our liver, 3 grams a day. Love it. So little pain pearls, take haste with waste. So remember, if you are preparing or wasting medicine, the best practice is to have the second nurse or the witness nurse with you as you prepare it, because otherwise I don't know if it's saline water, where the other half went, things like that. And then same thing, try to brush up on wasting with proper protocol. So what if they're wearing a fentanyl patch? Where does the patch go? Just in the trash can? And so it's gonna, facility dependent, but it's gonna have special throwaway. It just doesn't go in the trash can. What about if your patient, there is I don't remember if it's a fentanyl patch or an oxycodone patch, but there's a patch where you have to leave one, and I'm gonna go barefoot, I'm sorry y'all. They're gonna have to overlap or have an hour to 3 hour overlap, because the old medicine or the patch has not been absorbed and reached to become effective yet. So don't forget to go and take off the other patch, because technically you could overdose them if you don't remember to take off the other patch. PCA pumps, when we get to more of those in a critical care setting, but remember with those, when you're wasting the syringes, go in there with that witness nurse, because you're tampering with the equipment. Family safety stuff, like don't let the family or another person press the button, that is the patient's button. Just kind of all the administration stuff, not necessarily about the drug itself. Tolerance versus dependence, that's the one we were talking about, where your chronic patient may need more than the standard because they're accustomed to taking something routinely for chronic pain. So make sure that you can get them some extra. And then that's what your patient's gonna look like, our little kitty cat over there on the opioids. Remember to start low and slow, so start them on the least effective amount of pain medication before we just go in there. So if there's an order for morphine 2 milligrams, morphine 4 milligrams, go ahead and try the 2. Just say, hey, we got you some morphine for pain, don't have to throw the milligrams, because what you're gonna do if they, in 30 minutes when you do that recheck, tell you they're still in pain. You can administer 2 again to equal that 4 and then document that they received the 4 milligrams, but do the 2. Does that make sense in your charting? So start with the lowest one. OIC, opioid-induced constipation. So things you can do to help with that can be ambulation, fiber, hydration. So just add those in. Just be a good nurse. Don't wait until they get constipated. Stay on top of those BMs. And then with your other classes, so your cystillates and non-cystillates, those cause liver toxicity and GI bleeds. So to head them off at the pass, you're going to put them on a PPI. And what's your favorite PPI? I love it. Omeprazole is good. Pantoprazole, something like that. So you're starting to see why all your patients in the hospital get statins and pantoprazole, Protonix. So if they're a heart patient or have a heart history, they're getting some sort of blood thinner like heparin, Lovenox, or aspirin, and then they're all getting pantoprazole because of that. And then the most common side, so starting to hopefully come full circle for you. Questions on your pain meds? Moving on for your diabetics, we recently hit those with Celreg, so I won't spend a whole lot of time on this one because you'll have that close by in your brain. But your 3 pills, because I gave you a whole lot of pills. We had the DPP4s and a whole bunch of, these are the ones that you'll actually clinically see. So that's the one where, because I bet you've seen metformin by now. And then less common but still around is the glimepiride, which is your secretagogue. Remember, those help your pancreas to secrete extra or additional insulin. And then your sensitizers, like your pioglitazone or glitazones, those are going to help your insulin attach better to the cell and be more effective. And then your insulins, I think you're good, but down at the bottom, your other injectables, those GLP-1s, like your Ozempic and tirzepatide, they all end in tide. I'm trying to remember Ozempic, semaglutide, they all end in tides. Okay, what was the problem with those? You ain't gonna poop, you don't lock your GI system up. So, things we need to consider or teach these diabetic patients, that's what they're gonna be feeling like, high or low. Remember the little acronym, cool and clammy, they need some candy. Hot and dry, their sugar's high. And then know if the patient has had these episodes before, what were their specific symptoms, so that if you see them on their behalf, you can intervene early. If you've not mixed clear and cloudy insulin yet or in a while, review that process. So remember, you inject your air first, and then you're gonna draw up. So which one would you draw last? Cloudy, because if you had some clear left over, you could waste it in there, something like that. And speaking of clear and cloudy, you're going to watch your patients who are on PO anti-diabetics for the likelihood of UTIs, because remember, we excrete the extra sugar through the urine, so they're high risk for UTI. So making sure they don't have any urinary symptoms if they're a type 2 on orals. Food on the floor, you're not going to inject them until the food has reached the unit, so you have it prepped, and as soon as the tray's in their face, that way your action time or your onset time matches with your metabolization of the food. Perfect. And then your 15-15 rule, got that. There's your standard 15 grams of carbs, you're going to get a unit of insulin, or if they're acute, the 15 and that. So also another safety thing, if your patient is not able to follow basic commands, do not give them an oral option. Give it to them in the IV or in the muscle. GIs, you got 3 classes here. Your H2 blockers, which is going to be like your Zantac, Zegrid, Tagamet, I forget the other one, but anyway, all the deans. Ranitidine, cimetidine, famotidine. Those are going to, so H2, what does H go with in the stomach? What's your hydrochloric acid? So H2 blockers are gonna do what then? Blocking it. So you're gonna decrease the amount of acid that is being produced. That's how that works. Is what your H2 blockers do, is decreasing the amount of acid that is being produced. And then your PPIs, proton pump inhibitors, those are kind of be like a silk lining on your stomach, if you want to think about it that way. They're going to keep those proton pumps on the out wall of the stomach, the gut, protected so that the acid does not burn as much, or it's kind of a protective coating. Thinking about those two classes of medicines, what would be a safety concern or a nursing concern if you're giving them something that's going to decrease stomach acid, or you're going to block the stomach lining? What could happen to anything else you're giving? So I'm worried about if they're on those medicines, giving them at different times for absorption purposes. So the best practice would be to give it, Anna, what's your 30 minutes before, 2 hours after? I always get the times mixed up.
1 hour before, 2 hours after.
Thank you. She's got
Like
it
Sucralfate.
easier.
For which one?
For just any GI agent that's gonna coat your stomach.
Because
Because
it's
it's
gonna
gonna
block
block
food
absorption.
or other medications. Yeah.
I like her fluffy times better than the textbook times, so that's easier to remember. But yes, you're gonna inhibit them. You'll also see, another one that's kind of given off and on its own is gonna be that levothyroxine, which is your thyroid one, not on the presentation, but it's one that's given off separately. Then you've got some laxatives, things to make them poop. The osmotics, that's gonna pull water into the colon and try to help use your body's water stores to do that. So rather than dehydrating your patient to do that, that's why they tell you to give the Miralax with 8 ounces of water, because you're replacing the water that the medicine's using to pull water into the stool. Your softener, docusate, colace, just a greaser, bulk forming, and examples like your Metamucil or psyllium husk. So need to give that one also with plenty of water, because that one can cause obstructions. And then you have your stimulant. We like Senna first because it's plant-based, but bisacodyl / Dulcolax, those would be stimulant. So we could go through and reteach all of those. So osmotics and bulk forming, give with plenty of water, stool softener, no special rules there. Stimulant, what don't you like about stimulant?
If they have a blockage.
They could, if they have a blockage, worsens cramps. What else about if they take it routinely?
It could actually reverse.
Not codependence, yeah, because if your colon's used to having a medicine make it do peristalsis, they'd be like, we're just gonna wait on the medicine. So they can become dependent. So using the stimulant sparingly. There's not a Pearl section for this one, because there's not a whole lot of patient side effects. It's more about intervention, so don't give medicines with these. Obviously, if your patient becomes on the diarrhea side of things, then you could decrease or stop giving those. Like if they had several ordered, stop a few first, see how they do, and then stop all if they continue to experience diarrhea, things like that.
Della made a stance on that during clinicals.
I want to hear.
About not giving the Nocuset to the guy.
Oh, yeah.
Crapping on
I had to clean him up twice.
We're not doing it.
Right, that poop bomb did it.
Well, he was on.
Which, have y'all learned the poop bomb recipe? This would be the perfect slide to stick Fuller's poop bomb recipe on. It's just for
We know it, I
funsies,
don't know.
not quiz. Huh?
The prune juice.
You got prune juice, you got 3 things.
Warm milk.
Warm milk and coffee. Love it.
Warm apple juice does it too.
It can, yeah.
Oh, God.
I've been saying, but the prune,
It did.
prune bomb will always
The
work.
hallway was rough.
Blood thinners, you got 2 classes, but regardless of which class they own, what's some lab work you're gonna look after, monitor? PT, INR, APT, all things. So what would actually be your side effects or things to look for? Bleeding, signs of bleeding, bruising, hematuria, just anywhere the blood is that you don't want it to be. The most important thing, other than the 2 antidotes you have to know, and those are coming up on an antidote slide, I would like for you to know just yes, my blood thinner has an antidote. No, it does not have an antidote. The reason for that would be is if your patient is having to go to surgery, I would need to know, like if they're on chronic blood thinners, I don't know, colon's ruptured and they're leaking out into their body cavity or something like that. I need them to go to surgery now, I ain't got time to wait, they're gonna get sepsis and die. So I can give them the antidote and go on with it. If not, and I have to proceed with emergent surgery anyway, I need to go ahead and type and cross them and have blood on standby because I know they're gonna bleed like a stuck hog. So that's where the antidote thing comes into a difference. Now, by no means do I expect you to know every single antidote because they have some funny names. For example, for Plavix, that clopidogrel, it's like a Dexant Alpha. I don't expect you to know that because we don't give Plavix enough on a medical surgical floor for you to know that. But I do want you to know that it does have an antidote or it does not have an antidote. So that way you can save your patient. So heparin, Lovenox, all the ones you give at clinical, do they have antidotes?
Yes.
Yes, so it'll probably be on one of those, not on one of these weird ones. But I do want you to know if it has an antidote or not. So speaking of antidotes, here they are, the ones that you will need to know. What? There's only like one that's not one that the rest of them I think you already know. There's only one new one for us, and that's the anticholinergic. Remember, those were the tropiums. And so those are going to be physostigmine. Physostigmine is the only new one. It's number 4 down there. Other than that, I think you know them. So the opioids, narcotics, naloxone, heparin and enoxaparin get protamine sulfate. Then Coumadin gets the K. I even spell Coumadin with a K just for that reason. It gets vitamin K. Benzos, flumazenil. Acetaminophen gets mucomist. That one's going to be an inhalant. Remember, that's the one that smells like rotten eggs. If you've ever smelled mucomist, it's awful. It literally smells like you ate all the deviled eggs at Thanksgiving and then passed flatulence on your classmates. Mucomist is pretty bad. So usually, obviously, your greatest intervention there is getting the patient to leave it on their face so that you can fix their Tylenol overdose. If they have an overdose of magnesium, we're going to give them calcium. Beta blockers or hypoglycemia both get glucagon. Isn't that cool? So if they took too much beta paste or too much metoprolol, we're going to give them glucagon. Helps those beta cells. And then too much aspirin, just depends on your facility, either bicarb, because we know that aspirin causes metabolic acidosis in overdose, so some physicians go with the bicarb, or others will go to the activated charcoal, which deactivates the aspirin. So 2 schools of thought, but you'll see both. Okay? Moving on. So here's the time for farm practice. So we're going to let you actually apply some of this stuff to some scenarios and see what it might look like both for study and for getting ready. So the first thing would be your exemplar practice or your exemplar homework. It's not going to show in the recording, but I'm going to talk about it. My best recommendation to you would be to go to, you remember during orientation you were given this topical outline, and you can kind of go through those diseases, and we can talk about all the drugs that are out there. So all your drugs first. So what are some hypertonic fluids? Let's start iso. What's isotonic? Who? I like lactated ringers.
Normal saline.
Saline, which is, I call it isotonic number 9 because it's 0.9% sodium chloride. So starting there, and then just refreshing. Why do we like that class?
Because they're
Compatible with our blood products, they're compatible with body fluids, so they're not going to cause a whole lot of fluid electrolyte shifting. They're going to add volume. You see where we're going? And you can kind of exhaust all that and just talk through all of it. So blood products, even though we're not doing drugs, if you wanted to go back and study it just even for your HESI final. So studying some blood products, we got cryoprecipitate, we have packed red blood cells, we have fresh frozen plasma, we have, and literally talking about all those. And so if your patient has a reaction, AFH, what you gonna And so after our exam 4, we're gonna have a drill down session very much like this, where we'll go back through and we'll just ask general questions to bring it all back to your brain. But we're gonna focus on meds, so we're gonna skip that for now. Metabolic acidosis, there was only one medicine that we talked about for acid-base imbalance, and that was bicarb. And bicarb's just a fancy thing for baking soda. Is there really any side effects to baking soda that you know of, other than I might send them into alkalosis, but that'd be your only one there. What about your electrolytes? So if we had to replace them, so we had to replace sodium or potassium or one of those. When's the last time y'all looked at those? So sodium, how are we gonna replace it? Yes, IV, I like that. How are we gonna do it? Fast, slow, quick, in the middle?
You better go slow, because if not, you're gonna have some cardiac arrhythmias.
You remember slodium? That little acronym on that slide, slodium. Because if we go too fast, it also causes cerebral edema, things like that. But the best recommendation would be go through there and do those. The other option is you can literally go to that presentation. So we're gonna go to fluid and electrolytes. And you're gonna scroll through that presentation and you're gonna look for anything that has to do with drugs or medicine. So then, nope, that's acid base. There's only one, and it's bicarb, so save you the time on that one. Fluid and electrolytes, go to your little PowerPoint.
Is there really a lot of form questions on this?
It's always proportionate to how much content. So what's left for exam 4, divide that by 50 questions, and you can get an idea of how many there may be. And as said previously, it's going to be on drugs that you see commonly at clinical. It's never gonna load, apparently. There we go, I've talked bad about it. But you just roll through, we're looking for a drug slide, which there is one abbreviated one, I know. It talks about giving them all. There it is, there's your electrolyte replacements. And then there's diuretics, what to look for there. There's some IV fluids. So it just gives you some things that you will commonly give. And then we could fast forward and go to like oxygenation. Literally go through. Anyway, look for medicines. Thank you. Ooh. So look at there. There's a SABA. Give me a SABA. What's the beta 2 agonist?
Short acting is albuterol.
Albuterol. So all your Turols. All right, then SABA or long acting. What was that leukotriene agonist? Who? Montelukast. Simulator. There it is. So you're just pulling your drugs off that McCarty had for you, and then oh, he did better than me. He's got them all in there. So you ain't even gotta go look. Just get those back in your brain. What you looking for? There's your steroids. You see how to play the game. So don't spend a whole lot of time. Just have a nice general picture. So like for steroids, without getting too much in the weeds, what are some side effects of your steroids? Hulk stuff, hyperglycemia, mood lability, so they're angry, all that, polyphagia, they want to eat and drink a lot. Then what about if they take them over a long period of time? Immunosuppression, and what about bone loss? Remember osteoporosis for that, for bone loss? So that's kind of how you're going to play the exemplar game. So moving on. There, I've got you a handout, so the lights sadly are gonna come back on. Womp womp, I know, you gotta see the read. So I'm gonna get those back on.
Unless you have good eyes like Sam.
I'm gonna give you